My name is A.G. Block. I'm the Associate Director of the UC Center here in Sacramento. And we want to welcome you to the first of our Thursday seminars for spring quarter. And we are delighted to welcome back Dr. Gerald Kominiski, Director of the UCLA Center for Health Policy Research at the Fielding School of Public Health at UCLA. Dr. Kominiski is an old friend and an old colleague here at UC Center, having taught in the policy program here in 2008. Dr. Kominiski earned his doctorate in public policy analysis from the Wharton School at the University of Pennsylvania in 1985 and joined the faculty at UCLA in 1989. He's been there ever since. His research focuses on assessing the impacts of health reform, and that's what's brought him back here to Sacramento today to talk about what we commonly refer to as Obamacare and its impacts and potential impacts on California. Yeah. So with that, Dr. Kominiski.
Thank you very much. It's my pleasure to be here today to talk. Thank you. Thank you for that warm welcome. It's a pleasure to be here today to talk about the Affordable Care Act, what's also known as Obamacare. As I've told audiences over the last 3 years, the Obamacare term was really a pejorative description of the law. Probably for the first 2 years, political opponents to the law decided to use that label as a way of mobilizing opposition. I was pleased to see that during the last presidential campaign, the president finally came out and embraced that label himself and said, I'm proud to call it Obamacare. He should be. It's probably, unless he does something considerable in the next 3 years, it's going to be his signature accomplishment. Is certainly his most important, not his only, but his most important accomplishment to date, and probably perhaps for his entire presidency. But we'll see. The jury's still out. But I want to talk about work that we've been doing at UCLA in collaboration with colleagues at the UC Berkeley Labor Center, estimating the expected impacts of ACA in California. But before I do that, I want to also talk a little bit about what's in store in terms of the provisions of the ACA that are being rolled out this year and what that means in terms of insurance markets and insurance products. So for the first 10 minutes or so, I'm going to give you a little bit of just factual background about what's in the law and what's being implemented and rolled out now and has been for the last year and a half or so, what's in development. So let me start by talking about individual mandates, penalties, and subsidies under the law. So what's coming in 2014? We've all heard about the individual mandate. This was the basis for the constitutional challenge to the law. Almost immediately, 26 states filed suit against the law challenging the individual mandate. The individual mandate, starting next year, will impose penalties for being uninsured. Actually, next year the penalty will be $95 a person. This is the figures that I'm showing in the slide are the figures as of 2016. But by 2016, individuals will be responsible for paying a $695 penalty if they're not insured, up to a maximum of $2,085 per family, or 2.5% of income, whatever's greater. And as I think everybody in the room knows, this was the provision of the law that was found to be constitutional. The Supreme Court said, and specifically Chief Justice Roberts said, that this aspect of the law is not unconstitutional. It's well within the power of Congress, its taxation authority, because this penalty will be paid in the form of a tax. There'll be a new line item on our 1040s next year where we're going to have to supply information. We're going to have to verify that we have qualified insurance. And if we don't have qualified insurance, we're going to be expected to write in a $95 payment for being uninsured. Now, there are exemptions from this. I'm not going to go through all the exemptions, but there are low-income exemptions, and I'll talk a little bit more about that because that has an impact in California among the remaining uninsured. So not everybody is going to be subject to the penalty. But the point is that these penalties were put into the law to encourage people to buy health insurance rather than to sit on the sideline. And I'll explain in a moment what other expectations are of individuals in the new market. Another important provision of the law is the provision of subsidies, and this in some sense is the most important feature, the single most important feature of the law. For the first time, we're going to subsidize uninsured individuals to buy private health insurance in regulated marketplaces. The subsidies are in the form of tax credits. As I mentioned, this is an advanceable tax credit. It means that when you apply for the subsidy, it will be supplied after verification of your income through the IRS. The value of the subsidy is going to be based on the cost of a silver plan in your market area, and specifically it'll be based on the cost of the second lowest cost silver plan that's offered in your market area. And I'll tell you about silver plans if you don't know about them in just a minute. That'll be on the next slide. Subsidies are available for families and individuals up to 400% of federal poverty level. And I have this year's federal poverty limits at the bottom of the slide. So 400% of FPL is approximately $56,000 for an individual this year. For a family of four, it's approximately $94,000. So families that are uninsured or families that are currently insured but are within these income limits or up to that income limit can qualify for a subsidy to buy insurance in the exchanges starting next year. The law also establishes limits on family out-of-pocket spending for premium that range from 2% to 9.5% of income between 100 and 400% of poverty. So the amount that you will be responsible for if you qualify for a subsidy is going to be tied to your income. At the low end, you'll pay 2%. At the high end, you'll pay 9.5% of your income. But that's your share of the premium. The government subsidy will make up the difference. And again, it'll be the difference between what you're paying and the cost of that second lowest cost silver plan. And then the third major element of the bill that's unfolding this year is the expansion of the Medicaid program for individuals with income less than 139% of the federal poverty level. Now, this is the part of the bill the part of the law that is still the most controversial, because this was in fact the provision that the Supreme Court found last year was unconstitutional. Not the expansion per se, because the Medicaid program is not an unconstitutional program, but the mandatory expansion with a penalty on the part of the state if they fail to expand their program. So the law originally said that states that fail to expand their program were going to lose all of their Medicaid funding. And the Supreme Court found that this was an excessively punitive feature of the law and ruled it unconstitutional. What that did is it opened the door for voluntary expansion. And as I think many people in this room are well aware of, voluntary expansion means that about 26 states, and it just so happens the same 26 that filed the original lawsuit, are saying, well, we're not going to expand our Medicaid program. Now, I don't have a map today to show you what the current progress is, but we do know that at least 8 Republican governors to date have expressed interest or are committed to expanding Medicaid in their states because of the amount of federal subsidies that are available. So politics now are being trumped by the economic reality that failure to expand the Medicaid program not only imposes a considerable burden on the low-income population in your state, but it also means the loss of literally billions of federal dollars in subsidies moving forward. And I just also want to point out that the Medicaid expansion is fully funded by the federal government for the first 3 years for the newly eligible population, and then phases down to 90% support by 2020, and will remain at that level moving forward. What else is changing in terms of the marketplace? Well, the law requires the creation of standard health policies in the individual and small group market. And just to put that in context, nationwide, when we talk about insurance markets, we generally talk about the large group market, small group market, and the individual market. Small group market in the law is defined as employers with 100 or fewer employees. So if we use that definition in the federal law, the large group market covers roughly 65 to 70% of the insured population, the privately insured population in the United States. The small group and individual markets then account for roughly somewhere around a third to about 30% of the remaining privately insured market. So the law is targeted at that small group and individual market. It largely leaves the large group market untouched, not completely, but the fact is that the majority of Americans get their private insurance through their place of employment. They are in the large group market, and although some of the provisions of the law affect the large group market, these major changes are taking place in these other two marketplaces. So what does the law say? It requires, first of all, the establishment of qualified health plans, QHPs, all having the same essential health benefits. Now, what does that mean? Well, states have the authority to establish a benchmark for essential health benefits as the law has been interpreted. And in California, the benchmark that's been selected is the Kaiser Small Group 30 plan. So you can go online and look this plan up. And that's the basis for California's essential health benefit package. So the law provides sort of a general framework or outline for what essential health benefits are, but leaves open the option for states to define exactly what those essential health benefits are going to be. However, they have to comply with federal regulation that says that essential health benefits must include services in 10 categories. I haven't listed all 10 on this slide, but they include the typical things that you'd expect: inpatient care, outpatient care. But they also, essential benefits have to include prescription drugs, for example. And not all health insurance policies today include prescription drugs as a standard benefit. Moving forward, the essential benefits have to include prescription drugs. They have to include coverage for mental health and substance abuse services, also common but not by any means necessarily universally offered today in the private insurance market. And then also coverage for what are typically not provided, pediatric, oral, and vision care. So the essential health benefit packages are relatively generous, and the requirement for essential health benefits are relatively generous. The law establishes 4 tiers of these qualified health plans or essential health benefits, and the 4 tiers are known as the medal tiers. And the medals are, I originally thought that the medals applied or were based on the Olympic medaling system, medal with a D. Apparently, that was not correct. It's medal with a T, because these are also all metals that you can mine. But bronze, silver, gold, and platinum plans. So what are the differences between these plans? They all have the same, they have to have the same essential health benefits. So the bronze plan, which is intended to be the most affordable here, is not different from the platinum plan in terms of the benefits offered. It's the same covered set of services, health services, that have to be covered. The way that they differ is in their actuarial value. So what does that mean? Actuarial value is not, unless you work in actuarial science, that term probably doesn't mean anything to you, but the actuarial value of a plan is the proportion of the total claims experience that's covered by the premium versus how much is covered by out-of-pocket spending. So with that definition of actuarial value, how does the bronze plan differ from the, say, silver or platinum plan? The bronze plan has an actuarial value of 60%. And I'll show you what the bronze plan in California looks like in a minute. A 60% actuarial value means that the premium is going to be relatively low, but when you go to use services, your co-payments and out-of-pocket spending is going to be relatively high. So the best way to think about this is similar to, and you'll see this graphically in just a second, this is a high deductible plan. And I'm sure a lot of people in the room currently have high deductible plans. These have become very common in the marketplace. So You save on the premium, but when you start using health care, you have a lot of out-of-pocket liability. And on average, the out-of-pocket portion is going to be 40%, and the premium is going to cover 60%. So you pay less up front, but more when you start using service. Well, the Platinum plan is just the opposite. You pay more up front, but when you start using care, you have very little copayment. And as a result, you're basically prepaying for your health care services. The other plan that's going to be available through the exchange is what's known as a catastrophic plan. And this is offered specifically to young adults under age 30 and will be even narrower in terms of have a lower actuarial value than the Bronze plan. This is truly a catastrophic policy in the sense that it will have a cap. You pay the first $6,000 or $7,000 out of pocket, and then your insurance kicks in. But the catastrophic policy is intended to bring the so-called young invincibles into the marketplace, young adults who say, well, I have no need for health care. I don't need health insurance because I've never been sick a day in my life. And I know I was a young invincible at one point in time about 30 years ago, and then I had an appendectomy. And then suddenly I had a bill for $15,000. Now, I didn't have to pay that bill because I had student health insurance. But, you know, we're all one accident or one event away from having a catastrophic health expenditure, no matter how healthy we are. These qualified health plans also have to meet other provisions, including limits on out-of-pocket spending, and I'll show you that as well. I have figures here that are slightly different from what they'll be next year, but roughly $6,000 a year for individuals, $12,000 a year for families. And this is an important financial protection for families because what it means is that all new policies, no matter whether it's a Bronze plan or a Platinum plan, will have to have these limits or these maximums in terms of out-of-pocket spending. So you could buy a Bronze plan, which is low premium, high out-of-pocket, and at most, as an individual, you'd have to pay about $6,000 out of pocket. After that, the plan would have to pay for all of your expenses. And these limits are going to be lower for individuals with income between 133 and 250% of poverty. Plans also have to comply with guaranteed issue and renewal requirements. It means that an insurer has to issue you a policy, cannot deny you coverage for any reason if you have the money to pay for the premium. They also cannot deny renewal of your coverage. Let's say if you become sick and start spending a lot of money under your policy, your insurer can't say at the end of the year, we're declining to renew your policy for because of whatever, fill in the blank, whatever made up excuse, where the real reason is that you're costing us too much money and we'd like you to move on to somebody else. That will no longer be allowed. Finally, the plans all have to comply with, have to eliminate lifetime and annual dollar limits on benefits. Now, this is pretty common now, and the fact is that most of us never encounter these limits, but if you have a catastrophic event and spend more than, let's say, $100,000 in a year, you could actually, under some policies today, run out of coverage. That will no longer be allowed starting next year. So I promised you that I'd show you what these plans look like. This is from the Covered California website and is an example of what the Platinum, Gold, Silver, and Bronze plans that have been approved for sale in the California marketplace next year. Now, what Covered California did is it went one step, and the California legislature went one step beyond the Affordable Care Act requirements and said, not only are we going to offer these standard tiers, which is required by the law, but we're also going to standardize the co-payment and co-insurance rates for services within each of these plans. What that means is that in California, a Bronze plan sold by, let's say, Kaiser is going to be exactly the same in terms of the co-payment structure as a Bronze plan sold by Anthem, as a Bronze plan sold by Aetna, as a Bronze plan sold by HealthNet. They're all going to be the same, not just the same benefits, but the same out-of-pocket co-payments for all of the services listed in this slide. And I just want to call attention to the fact I mentioned, the bronze plan is intended to be the most affordable. The bronze plan has a $5,000 deductible, but a $6,400 cap on out-of-pocket spending. So this bronze plan is kind of an interesting policy. You spend $5,000 out of pocket, and the only real coverage you have are for preventive services. Preventive services have to be covered without being subject to a deductible or copayment. But everything else you'll have to pay out of pocket up until $5,000. At that point, your insurance kicks in, and you'll have copayments that are determined by this schedule here. But then when you get to $6,400 as an individual, now the plan will pay 100% of the cost after that. So it's a very interesting kind of plan. It's a high deductible plan with a lot of spending, a small corridor where you're getting coverage, partial coverage, and then almost immediately you'll get full coverage for all of your care because you've met the annual limit. And you can see here that the Platinum plan, in contrast, has no deductible at all and has a $4,000 annual limit on out-of-pocket spending. So you'll spend more for the premium here, but you're going to have a lot smaller or much fewer copayments. And in order to keep that 90% actuarial value rating, the plan has to have a lower annual limit on your spending. So this Platinum plan is going to look attractive to people who know that they have regular medical expenses, have a chronic illness, or maybe expensive prescriptions. The Platinum plan looks like a much better deal for somebody who has regular, relatively high, but not extremely expensive health spending. So those are the policies that are going to be offered next year in the exchange and outside the exchange. But let me talk about these exchanges. The law also requires the creation of new private insurance markets for the small group and individual market next year. It requires the establishment of an exchange. We have an exchange in California. It's called Covered California. And it includes an individual market exchange and a small group business exchange. It allows only the qualified health policies that I described in the previous slide with essential health benefits to be sold. And here's the key, a key factor in the law. It requires that these standard policies with essential health benefits be sold in the exchange and outside the exchange. So you don't have to buy insurance in the exchange next year. Let's say today you're in the individual market. Next year, you do not have to go into the exchange to buy a policy. But if you buy a policy outside the exchange, it's also going to follow all of the same requirements that I just described in the previous slide. It's going to have to be a qualified health plan with essential health benefits. It won't be called a qualified health plan because, technically speaking, the qualified health plans are the ones that are sold in the exchange. But it has to be exactly the same as the QHP that's sold in the exchange. It'll have to be a metal tier plan. It'll have to have essential health benefits, meet all the other requirements. And even more importantly, if a company sells a bronze plan in and outside the exchange, they have to charge exactly the same premium. They can't try to risk segment the market by charging one premium outside the exchange and a different premium inside the exchange. The premiums have to be exactly the same. It requires that insurers set the premiums for these plans. Now, I showed you in the previous slide what Covered California has approved next year for sale in the market, the structure of the gold and silver and platinum and bronze plans. But we still don't know what the premiums are going to be. But we do know what the rules are for establishing the premiums. The premiums can be set using what's known as modified community rating, and it means that they can vary only on the following basis. They can vary according to the age of the insured. They can vary according to tobacco use, family size, and geography. Now, that's what the federal law says. What are we going to have in California? Well, we will have age used as a factor. The law says, though, that the range between the lowest cost age group and the highest cost age group cannot be more than a ratio of 3 to 1. Now, that's significant because currently in the marketplace, the ratio is typically 5 or 6 to 1. And what this means is that we're going to see some age compression in California and across the nation. It means that older people who are buying insurance today will end up paying less, and younger people will end up paying more as a result of this requirement. Tobacco use in California is not going to be used for setting premiums. And there's a real debate, especially as a public health professional, I can tell you that in public health we view this as really kind of reprehensible, that we should not be charging cigarette smokers more for health insurance premiums. But I can also tell you that I've given literally 100 talks on this topic to a wide variety of audience, and there's a lot of popular support for charging people more for cigarette smoking. And that's part of the reason why it was in the law, because there is mixed opinion out there. But as a public health professional, I'm happy to say that California is not using this. There are more effective ways of getting people to stop smoking, and we actually in California have pioneered a lot of those methods. That's why we have the second lowest rates of cigarette smoking of any state in the country except for Utah. Family size, generally there are 4 categories, so it'll be individual, 2 adults, 1 adult with children, 2 adults with children. And geography is still being debated, so there are alternative proposals out there. There's one proposal for 6 regions in the state of California. There's an alternative for 19 regions. However we divide up the state, the purpose of this is to say that there is regional variation within a state, especially a state as large as California. And there are differences in the underlying cost, and there are differences in the underlying use rates. And the Bay Area, by the way, happens to be the most expensive in the state. So by regionalizing premiums, it means that you don't have one region that's low cost subsidizing another higher cost area of the state. If the Bay Area wants to pay more for health insurance, then we're happy that they do that. But down in Southern California, we don't want to subsidize that. And then finally, I think the last point here I've already made about retaining the existing markets and the same premiums. So I've given you an overview of what's in the law and what's coming. Now I want to switch gears and talk to you about work that we've been involved in with UC Berkeley. This is work that we've done for Covered California over the last 16 months or so. And we've developed a model that we call the CalSIM model. Basically it's a model for estimating who is eligible for benefits, both the Medicaid expansion and insurance subsidies, and more importantly, in some sense, not only who's eligible, but who's most likely to take up those benefits starting next year. And we've been doing a lot of work for the exchange to provide these estimates. So let me spend a little bit of time quickly summarizing the work that we've presented over the last, particularly over the last 6 months. So if you look at the column all the way on the left, it's sort of the current state of California. So our best estimate is that on any given day, there are about 5.8 million Californians who are without insurance. And I stress that on any given day because the numbers that you see about the number of uninsured in California range from the 5.8 figure that I just gave you to as high as 7 million. And the difference between those numbers is that one's a daily estimate at literally a slice in time, whereas the other's an annual estimate. And the point is that over the course of a year, people become uninsured and then in some cases they become insured again. So when we look at anybody who's been uninsured at any time during the year, the estimate's about 7 million. But all the numbers that I'm focusing on in my presentation focus on at a specific point in time. And about 4.9 million of those are people who are legal residents or citizens, and about 900,000 are undocumented. That's under the current, under sort of current conditions. So what's likely to happen under ACA? Well, we've been modeling 2 scenarios for the exchange. One we call the base scenario and the other the enhanced. And this is really based on work that that the Congressional Budget Office and the Urban Institute have been doing when they've been modeling the impact. So we've been sort of mirroring their assumptions and approach to looking at this. Under the base model, we assume that most people who are currently eligible for Medicaid are not going to sign up. In fact, the base model assumes that only 10% of people who are currently eligible for Medicaid will newly sign up for benefits as a result of ACA. Under the enhanced scenario, we assume a much more active, proactive exchange that is doing significant outreach, culturally competent outreach, and as a result is more successful in enrolling people. And under that model, we assume also, in addition, that 40% of people who are currently eligible will enroll. Still a relatively low percentage, but much higher than under the base model. And so you can see that under these two scenarios, we estimate that even with the significant expansion of benefits and eligibility, that somewhere between 3 and 4 million Californians are still likely to be uninsured by 2019, which is when all of the aspects of the ACA are finally fully implemented. So just focusing on the enhanced scenario, of those 3 million who are still uninsured, 3.1 million, about a third are not eligible because of their immigration status. Another 29% are eligible for the exchange, but not eligible for subsidies because their income is above 400% of the poverty level. So it's the group in the red box that are actually eligible for ACA benefits but still not enrolled. And we estimate that about 400,000 Californians will be eligible for benefits but not taking them up in the exchange, in other words, a subsidy. And then another 800,000 will be eligible for Medi-Cal but not signing up for those benefits. So you can see that at least based on our assumption and the modeling that we've been doing, that a significant portion of Californians are still going to remain uninsured. So the rest of my talk is going to focus on who those remaining uninsured are. This slide shows that a majority of the remaining uninsured are exempt from tax penalties. So the purpose of the tax penalty is basically to provide a financial incentive for you to buy insurance, because if you don't, you're going to be paying a penalty anyway. So it's pure economic incentive. Pay a penalty or sign up for insurance. The fact is that only about 28% of the remaining uninsured under the base scenario, and that's where 4 million remain uninsured, about a quarter of them are going to be subject to the penalty. The rest are exempt either because of their immigration status or because their income is too low or because they don't have affordable coverage. And I'll talk more about the affordable coverage in a minute. I have a slide that explains that. So the point that I want to emphasize is that a significant number of people who remain uninsured will be exempt from the penalty. And we think that that's a primary driver for why there will be a high percentage of uninsured in California. The affordable coverage. So we estimate that almost 40% of Californians who remain uninsured lack an offer of affordable coverage. And the law says that affordable coverage is defined as paying less than 8% of your family income for health care. Why does such a large percentage lack affordable coverage? Well, one, again, undocumented immigrant status. The second are people who qualify for exchange subsidies, so their income's between 250 and 400% of poverty. But according to the law, in that income range, you're supposed to pay either 8% going up to 9.5% of your income. Now, you qualify for a subsidy, but you're paying more than 8%. So this is actually kind of a peculiar. There are two aspects of the law that are kind of in conflict with each other. There's the affordability aspect, which says if you pay more than 8%, then you're exempt from having to pay a penalty. So in other words, you could remain uninsured. But on the other hand, you could qualify for a subsidy as long as your income is below 400% of poverty, but we're going to require you to pay up to 9.5%. So it almost feels like somebody. Now remember, this law is the Senate version of the bill. There was a House version and a Senate version, but the House version never got acted on because of Senator Kennedy's death. So the House bill went away. So the law that was enacted was the Senate version without modification. And it seems like somebody on the Senate staff should have been doing a little fact-checking on this and said, wait a minute, it's either 9.5 or 8. Exactly. Let's just be consistent. If we're going to have an affordability standard and an exemption standard, let's make them the same percentage of income. It's either 8 or it's 9.5, but just be consistent. And I have to admit that I continue to find this confusing myself. But that's what's in the law, and at this point, it's not changing. The other reason for not having affordable coverage is family income over 400% of poverty and therefore not being eligible for an exchange subsidy. And then the final reason is something that is known in the field as the kid glitch. And this is, again, something that, in a sense, should have been fixed before the bill got to being signed, but there was no opportunity to reconcile this bill. It had to be voted on the way it was written. This problem is that if you're offered insurance through your place of employment and you don't have to spend more than 8% for individual coverage, even though you want family coverage and it would cost you more than 8% of your income for family coverage, as long as you don't have to spend more than 8% for individual coverage, you're considered to be having an offer of affordable insurance through your employer, even if you want the family plan and it would cost you more. So under this glitch, it means that your family members might go uncovered and they would not be eligible for subsidies in the exchange because you are deemed to have affordable coverage through your place of employment, even though it's not affordable. I'm sorry if that's confusing. I realize this is, in a sense, kind of a drilling down, but this is we believe that nationwide there are probably anywhere from 500,000 to 1 million kids and other dependent spouses who are going to remain uninsured because of this problem. And it really should be fixed. We've written letters to the Treasury Department as part of the regulatory process, but the only solution at this point is a legislative one. And again, there's no support at this point for going back and fixing this part of the law, given that Republicans in the House still want to repeal Obamacare, much less fix it. Right, much less fix it. The majority of remaining uninsured, we predict, are going to be Latino, and I don't think this should be surprising to anybody in the room, but under the base scenario where 4 million Californians remain uninsured, almost 2/3 of those are Latino. And the majority, because a substantial portion are Latino, they also, a significant portion are predicted to be of limited English proficiency. So we estimate about 60% of California adults who remain uninsured have limited English proficiency. Again, not surprising, Spanish is one of the most common languages for people who report that. About 80% are Spanish speaking, although other common languages include Chinese, Vietnamese, and Korean. There are geographic variations in the state, and again, I don't think this should be surprising to most people in the room, but we estimate that 62% of the remaining uninsured are going to be concentrated in Southern California, and a significant portion of that, those individuals are concentrated in Los Angeles County. But you can see that in most counties in the state, except for sort of the Northern Bay area and the counties extending directly eastward from the Bay Area, that the uninsurance rate within each county is still going to be around 10 to 12%, but it's significantly higher, 13 to 14% in Southern California counties. We also look among the remaining uninsured, at those who are below 200% of poverty. And we did this to say who are the most likely users of safety net services. And when we look at just that population, 200% and below, the number is almost 2.3 million. About 300,000 are eligible for exchange subsidies, 1.1 million eligible for Medi-Cal, and another 800,000 not eligible due to immigration status. So based on these findings, we believe that that the safety net is going to continue to be an important source of care for the remaining uninsured. So based on the work that we've done for the Exchange Board, we think that to minimize the number of Californians remaining uninsured, there has to be significant, strong outreach, particularly to Latinos. That language-appropriate outreach and enrollment are critical because of the high percentage of people we project as having limited English proficiency. And that focused outreach efforts, if you're going to target an area, and the point is that Covered California has to target the whole state. It can't afford to just focus on one area, but particularly strong outreach needs to be done in Southern California, and particularly in Los Angeles County. And so we estimate that the difference between the base and the enhanced scenario means almost 1 million Californians, about 800,000, would enroll in Medi-Cal or the exchange if those outreach efforts are successful. And I actually have every reason to believe that Covered California will be successful in its outreach efforts, but it is going to take a very active and proactive stance, not just this year, but over the course of the next 3 to 4 to 5 years, to educate Californians about what benefits are available and reaching out to communities that have been difficult to reach historically. We think that policy decisions affecting the safety net should ensure that care is available for the significant number of remaining uninsured Californians with income below 200%, because they are going to be users of safety net services. And some of the examples are provision of federal and state grants to continue to fund community clinics. There is a provision in the bill for increased funding of federally qualified health centers, and we think that that may be insufficient and may need to be increased. There are issues regarding the distribution of realignment funds and the allotment of DISH payments. So let me just switch gears quickly here for a minute before I finish and open it up, and just turn to another product, another topic that we're involved with at the Center for Health Policy Research, and that is something called the Legislative District Lookup Tool. For those of you who are not familiar with our center, we produce what's widely recognized as the definitive survey on California's, the health of California's populations, called the California Health Interview Survey. We've done 5 rounds of this survey over the last 10 years. We're currently in the field conducting the 6th round of the survey, and our CHIS survey is widely used throughout the state to assess the health status and the health insurance status of Californians, not just statewide, but at the county and in some cases sub-county level. But what we've done in addition, and what I'm referring you to in this slide, is that we've also compiled legislative district tables that allow you to download a table that has the number and percentage of constituents that are affected and how your individual district compares to the state. The estimates in this legislative lookup tool, and there are about 15 variables that we have in there right now. It allows you to take estimates from the 2009 California Health Interview Survey and look at state assembly districts, state senate, and U.S. congressional districts. And the districts are defined as the ones that went into effect in January and that will be in effect for the next 10 years. So it's 2009 CHIS data applied to the new legislative districts that were effective earlier this year. The URL that's listed at the bottom of the slide is how you can access this, and The presentation will be, I understand, will be available online, so you'll be able to find this. But you can also find the legislative lookup tool on our center website. So finally, before I open it up for questions, let me just give the appropriate acknowledgments. That I talked about our CalSIM model. I didn't really say anything about how it works other than what it does, but I have to not only acknowledge our collaborators at the Berkeley Center for Labor Education and Research, and Ken Jacobs is the lead there on that, but also our major funders for CalSIM. And that includes the California Endowment, the California Health Benefit Exchange, which is now covered California, Blue Shield of California Foundation, and the California Pan-Ethnic Health Network. And you can get more information about the CalSIM model if you're interested in technical details, as well as some of the work that we've done at the URL that's listed below. We have a dedicated web page just for the CalSIM work that we've been doing. So I want to thank you for the opportunity to talk to you about this important piece of legislation. I've got the websites here not only of our center, but also the Kaiser Family Foundation and the Commonwealth Fund. I find these two websites to be definitive sources of information about the impact of the law nationally. And of the two, Kaiser Family Foundation website is an absolute goldmine of information. I am accessing it at least 5 or 6 times a week. I'm downloading slides from many of my slides. I download directly from their website. They make it very easy to do. I highly recommend that you check this website on a regular basis for information, particularly on what's going on nationally with ACA, but also with Medicare, health policy, health costs, et cetera. It's just an extremely valuable resource. So with that, let me end the formal part of my presentation and open it up for Q&A.
If you
Thank you.
I actually have 3 separate questions, so you choose which one you want to do.
Okay.
So my first question I don't understand is for those who will get subsidy tax credits for their premium, how is that actually going to work out? Do I, as a poor person, have to pay up front?
No. So that's a great question. So the answer to that is no. It's called an advanceable tax credit. So what that means is that Covered California is going to have an enrollment and eligibility program called, everything has an acronym today, right? Their program is called CalHERS. CalHERS, which is going to be rolled out a little bit later this summer and then actually be in effect on October 1st. When you enroll, there'll be income verification that goes to the IRS. There are exemptions or exceptions because it's possible that your income has significantly changed since your last income tax return. Let's say you're unemployed now when you weren't when you filed your last return. So that would change your circumstances. But the point is they'll establish eligibility, and then whatever subsidy you qualify for is then credited to the insurance company that you select when you go through the enrollment process. So if you select the Kaiser Bronze Plan in the Bay Area, they'll transfer the payment directly to Kaiser. So your bill will be whatever the difference is, and that'll be based on your income. So, let's say you're required to pay 3% of your income based on where you are on that scale. You'd pay the 3% of your income, and then the subsidy will be transferred for the rest.
I'm just going to ask one more question, then I'll let you move on. And that is, we keep talking about the newly insured, newly insured in Medi-Cal. What's going to happen to people who are currently on Medi-Cal? Are they going to get these tiered plans to choose from?
No, the tiered plans only apply to people in the individual market and the small group market. Anybody in Medicare or Medicaid are not affected by this. If you're in Medicaid, you're in Medicaid. Now, having said that, that's from the beneficiary side. So you're not you're not picking a tier. If you go to Covered California and they determine that your income's below 139%, you'll be enrolled in Medi-Cal and given instructions about how to seek services and et cetera. For the state, it matters a great deal because the state will have to determine if you are a newly eligible person for Medi-Cal Or if, even though you're not on Medi-Cal now, but let's say you're signing up in October, if they determine that you would have been eligible under current law, not new law, but current law, so you have dependent children, let's say, but you didn't sign up for Medi-Cal even though you were eligible, well, the state's only going to be entitled to a 50% match from the federal government for you. But if you're newly eligible, the state gets 100% of the cost paid for by the. So it matters a great deal to the governor. And he's fighting with the counties right now over how to deal with that issue.
So I have another question along that line. With the Medi-Cal population, you say they'll remain uninsured. And I can't remember the number you thought would be uninsured that would be actually eligible for Medi-Cal. But once they present for services, won't they go into that clinic who won't get paid, or doctor who will then immediately sign them up?
Yep.
So they may not be on insurance now, but will your model change over time? Because it would just seem as soon as they go for services, they're going to become insured.
Yeah, I think you're right. So the point is that, yes, we're not projecting that people will get care and then disenroll per se, but that they'll remain outside the system as long as they don't need care. And that some people may remain outside the system and seek care informally. But you're right, there's every incentive for, especially for hospitals, because we're talking about high cost, but even for a community clinic, right? I mean, I've talked to directors of community clinics in Los Angeles County who are prepared to help their uninsured patients go to covered California and make sure they get enrolled in whatever they're eligible for. Well, first of all, you have to take. They're not all eligible for Medi-Cal. Yeah, so it's closer to 1 million for Medi-Cal. Yeah, over time that should diminish, right? But it may take a number of years, and frankly, we have not modeled that how that's going to occur.
We have a question on this side.
Thank you. Thank you for the talk.
Thank you.
Do you see this as getting us closer to a single-payer system where we can get rid of all this minutia of how we get enrolled and everything? Thank you.
Well, I don't see this as close to a single payer. In fact, I still say no, but for the following reasons. And it's not because I'm personally opposed to single payer. I actually think that a single payer system is a more reasonable, and a number of studies have been done, including a study that was done here in California about a decade ago that shows that we can insure everybody in the state and save something like 15% of our healthcare expending by having a single payer system. That aside, I don't feel that the Affordable Care Act moves us closer to a single payer, because what it does is it kind of shores up the existing system. It keeps Medicare, it expands Medicaid, and by the way, nationally there are still people who are strong supporters of the law who feel that Medicaid expansion might, in some states, cause the system to break because it's not prepared to expand that much, that quickly, because the programs are not running at optimal efficiency or adequately funded. And certainly in California, if you talk to, you can talk to providers who say that Medi-Cal is the worst payer, and expanding Medi-Cal may be good for providing insurance coverage, but it's not good for providers per se. It's better than not having insurance, but it's barely better in some cases because it pays so little. And that's a chronic issue here in California in terms of payments to providers. But I don't feel that it gets us closer to single payer because it's shoring up the existing system. It's largely federal subsidies to buy private insurance. And that's, in my opinion, further away from a Medicare for all model than we'd like to be.
What happens to the billions of dollars saved by those 26 states that don't accept the Medicaid expansion?
Yes.
Does it go to the Treasury, or does it get reallocated within the ACA pot?
That's a great question. I think the answer is, I actually hadn't thought about that, but I think it's a savings to the federal government. It definitely doesn't go to other states. There's no question about that, because you can't recapture that money. There's no mechanism for recapturing the money. It just means that the CBO's estimates of how much the federal government's going to have to spend over the next decade. In fact, I haven't seen an update from CBO yet. I think the reason is because they still don't have a definitive sort of estimate of which states are actually going to expand their Medicaid programs. But they're going to have to update all of their scoring of this bill, essentially, to say, now that states are not expanding their Medicaid program, what's the impact on the federal government?
We have a question on this side.
Hi, Dr. K.
Hi.
Great presentation.
Thank you.
I think it was a slide before this one where you had the CalSIM model, where the undocumented, this one, the undocumented went from 1.07 million uninsured to 1.03. How does the model account for that if the undocumented are,
Why does the number change?
Yeah.
It's not a statistical fluke, and it's not an error. Okay. So the point is the undocumented aren't eligible for subsidies, and also are not eligible to buy insurance in the exchange with their own money, even without a subsidy, which I find, and talk about punitive measure. I mean, that's just punitive. But remember, the insurance market outside the exchange is going to have to mirror all of the provisions that the exchange is following. So the undocumented, we think with the enhanced outreach, there's just going to be more of an awareness of the need to be insured and the options. So that people will be thinking about buying insurance, even if they don't have a subsidy, and even if they can't buy it in the exchange, they'll be able to buy the same bronze plan for the same premium outside the exchange. Okay. And so that
was actually going to be my follow-up on that, was that if the plans outside, I wanted to see what the incentive would be for plans outside of the exchange to offer the same. I mean, if you're required to offer the same policies in and out of the exchange, like what's the incentive to do it outside of the exchange for the individual market? And I assume this is one reason, right? Or do you have any other projections on why else?
I think it's a good question that I don't have an answer to, because I think the purpose of the law is to say, if you make the markets essentially exactly the same, but in the exchange you have this comparison shopping and a user-friendly interface, et cetera, but outside it's still kind of a free-for-all. Now, meaning that's not to say that somebody, some enterprising entrepreneur might not create their own website to allow you to shop for non-exchange bronze plans. But yeah, I mean, it's likely to happen. But I think the intention of the law is to say to make the exchange so desirable that why offer policies over? But we'll see. I mean, the one thing I will say is that there's the ability of organizations to find ways of taking something and working it to their advantage is infinite. And there may be an advantage to continuing to market exclusively outside the exchange that is not immediately apparent to me, but will be discovered by somebody in the next 12 months. And then I'll be talking about it and trying to explain it, but I don't know what it is.
Hi, I have a related question, which is, other than providing a streamlined, efficient, one-shop space to buy health insurance, what are the policy reasons between having these two markets, an exchange and outside the exchange? And related to that, what are the different groups going to be like who purchase insurance outside the exchange versus inside the exchange? I know you touched on undocumented immigrants, but other than that, why would someone go outside the exchange or inside?
Well, again, I'll just continue what I said. I'm not really sure what the advantage of buying outside the exchange is going to be. So I think if there is an advantage, it's not immediately obvious to most analysts, to most economists. That's not to say, though, that there won't be an advantage that the industry discovers. I can think one possible advantage might be that you could offer the same policy with all the same benefits, but have a different group of providers. So, for example, at UCLA, we're offered a Health Net plan and then a scaled-down version of Health Net that has a more exclusive provider, narrower provider network. It's the same company, and it's the same health benefits, but one has a more restricted group of providers, and as a result, has a lower premium. Now, the companies are not going to be able to offer a lower premium for the plan outside the exchange, so that price advantage goes away. And that's the reason that I'm having a hard time predicting why someone would want to buy the policy outside the exchange when you can go to the exchange, get the same policy, even if you're not qualifying for a subsidy, you can buy it there, and you can comparison shop more readily. I'm just saying there's an element of this that I think a year from now will be clearer, but it'll be somebody in the insurance industry who figures out that there's a marketing advantage to continuing to offer certain policies outside the exchange that it's a little difficult for me to predict right now.
This is one of the most coherent presentations I've seen in the last 6 months, so congratulations.
Oh, thank you.
Without going perhaps too much into the weeds, regarding the calcium model, I've asked this question to Jacobs, to
Yes.
Dylan. What is the confidence level in terms of the modeling that you go?
In terms of
right, there are several data
variability?
sets. Right, there's
Yeah.
several data sets that are put together, and specifically the 2-3 areas that I'm interested in are there's an assumption that income is growing at a 2.5% per year based on last 10 years, but the last 10 years are prior to, I believe, the recession. There's a little bit of a behavioral economics involved, but the impact of the recession regarding potentially discretionary funds have not been actually, from my understanding of the modeling, has not been incorporated. The price and income elasticities are still from the early 2000s.
Mm-hmm.
And lastly, the same question comes back from the modeling in here is, if the plans are offered both in the inside and outside are the same, what is then the incentive, or what is the purpose of the Covered California, except for providing a service? Is that what it boils down to?
Well, I think the purpose of covered, let me answer that question first. That's the easiest one to answer. I think the purpose of Covered California is that the legislation says that we've got to have regulated marketplaces. So it was quite clear that Congress and the president were not going to propose a law that said we're going to create a new subsidy program to allow people to buy private insurance. And by the way, the private insurance industry gets to operate the way that it currently operates, which is to exclude people from the market here in California, medical underwriting, et cetera, et cetera, et cetera. So the quid pro quo was billions of dollars of new federal subsidies for private insurance, and in exchange, the insurance industry accepts federal regulation for the first time and standardization of the way that they operate, and the elimination of some of their more egregious tactics in keeping people out of the market. So that was the political and economic quid pro quo. In terms of our model, you're right, you've raised these objections elsewhere. I don't want to get into a discussion of our assumptions per se, but I will say that you're absolutely, I think, you have valid questions about the assumptions that go in. I will say that, like any other modeling exercise, the quality of what comes out of the model is only as good as the work that goes into it. As far you alluded to elasticities from a decade ago. The fact is that there isn't any good research in the last 3 years that we can use as substitutes. So we're using the best and most recent, and it happens to be 10 years old. In our field, people are still using results from the RAND health insurance experiment, which is over 30 years old now, because there's nothing better that's been produced, and in our lifetime, nothing better is likely to be produced because we're not going to reproduce that experiment. But I will say that whether you like our model, you believe it, you don't believe it, we're all going to see in the next 12 months whether we're on target or not. Because next year, I won't be standing here saying we project enrollment to be so-and-so. You'll have the actual enrollment in Covered California. They'll be publicly reporting how many people came and signed up. And you can judge for yourself. Were we reasonably on target? Were we totally off base? I don't think that we'll be totally off base, but we'll know in probably 12 months.
Hi, thank you. Dr. Kominiski. It's always nice to hear you and your lectures.
Thank you.
This is about the graying population as
Yes.
the aging population. I know Medicare is pretty much going to keep with their same rules and regulations, but I just want to double check with you on this. There's not going to be any limits and annual limits for benefits. That's for the exchange and things like that. But as far as Medicare, generally speaking, Medicare, unless you have those advantage plans,
That's
those
right.
supplemental plans, they have $2 million limits, and they have
That is correct.
65-day limits. Are those going to still stay in effect for Medicare?
Yes.
I thought
So there are separate discussions underway. The president is actually, my understanding is the president has embraced a possible Medicare reform that would combine A and B deductibles and copayments and make them consistent across the two parts of the program,
right.
as well as establishing a annual limit on spending. Because right now, Medicare beneficiaries have, you could conceivably spend an unlimited amount of money. There's no catastrophic protection, never has been under the Medicare program. So he's apparently embraced this notion of combining the A and B, unifying the deductible and copayments, and establishing an annual limit on out-of-pocket spending. And I think it's part of the overall deficit reduction discussions that are going on right now.
Great. I have a second question, but I'm going to email you. It's
Okay.
about one of your bullets where some of the insurers are taking advantage of a loophole. And my question would be, how does that negatively or positively affect us as beneficiaries?
Okay. All right, good. So we'll talk about that.
Thank you. Thank you very much. I have a question from the insurance company perspective, which is if they all have to meet the same standards as far as benefits, and is the only difference among the various insurance companies going to be a race to the lowest premium in the exchanges?
Well,
What other
in an
things will they
ideal
compete?
world, that would be the case. There'd be pure price competition on exactly the same products. And so, I mean, if it's not clear from my presentation, I'll just state it even more sort of succinctly. This legislation is intended to create standard insurance products so that people can shop and make meaningful comparisons, apples-to-apples comparisons. And the reason that California went one step further in terms of standardizing the copayment and coinsurance structures is California said the law, is a good step in the right direction, but unless you can standardize it so that people can easily understand it in a comparison table like this, I hope that everybody in the room can understand. I mean, this is still a little complicated, but this is how you comparison shop.
Sure. But I'm talking.
Of course they'll be different, and that's the point is that you can't standardize for that, and there's still going to be, so
What
when
are the
you
differences?
buy, if you want to buy the Kaiser Bronze Plan, you're buying Kaiser hospitals and doctors.
Okay, so it's the.
And there are 5.5
provider.
million people in the state who say that we think that that's what we want. And there are other people who say, I don't want a closed system, I want an open system. And within open systems, there's going to be, as I was describing, there's the Health Net, and then there's the Health Net restricted plan that has a more narrow network of providers, but saves me on my monthly premium. So, but the whole purpose here is to standardize the product so that people can shop. And if economic theory works, then you shop on price. But there will be other factors, including the quality of the provider network as well.
Relative to comparison shopping, I guess the only differential is going to be the premium, because I'm comparing the Platinum plan with the existing Kaiser plan that state employees have. This is far more expensive. Does that mean that all the Kaiser co-payments...
Oh, wait a minute, you said this is more expensive, meaning the co-payments are higher. Is that true over here?
Oh, absolutely. Well,
for the Platinum?
Platinum emergency room is $50 if you're not admitted into the hospital. No payment if you are.
Yeah, I mean, this is more expensive than my coverage in terms of these co-payments.
No,
And that's because
across the board.
Yeah, the university tries to make the actuarial value of our plans 85%. So it's supposed to be somewhere between these two, but these co-payments are higher than
But does that mean that anybody who is with existing university plan is going to have a dramatic increase in all of their co-payments?
Well, first of all, the university's exempt from this requirement because it's a large employer. Not required, but that raises another question, which is, are large employers, seeing that they're offering benefits that are more generous, going to start cutting their benefits? Is it going to lead to a race to the bottom? Now, that's one of the most common questions that I get in any presentation that I've given on this. And I'll say that we don't know for a fact, but I will tell you that the evidence against the race to the bottom is that we have a private insurance system in this country that's evolved since 1929, which is when the first private insurance plan was offered, Blue Cross. We've had private insurance for over 80 years in this country, and there's no requirement at all in the United States, with the exception of Hawaii, that employers provide health insurance benefits. So the fact that employers provide generous health insurance benefits is not because they're required to by state and federal law. It's because the market, labor economics, and total compensation has driven employers, with enormous assistance, by the way, from the federal tax code, right? Because remember, health insurance benefits are tax exempt. So it means effectively you receive a subsidy from the federal government when you offer insurance, because you can deduct those expenses, and it's exempt from the individual's personal income tax. It's not taxable income. So the higher your income, the more the benefit. So firms have known this for a long time and have exploited that aspect to offer generous health benefits. The ACA doesn't change the fundamental economics of the labor market, in my opinion. It does not say that companies can now begin to cut benefits without offering equal or some other compensation. And by the way, for every dollar you cut in health care, you have to pay about $1.25 to $1.30 in additional salary, because that salary is taxable. So I don't think that companies are going to race to the bottom. But I've heard others who say that in 5 years, no companies will be offering insurance, or they'll all be offering what's equivalent to the bronze plan. And I'm willing to say publicly that I don't think that's going to happen. And I hope that in 5 years this doesn't show up on YouTube and they see he was totally wrong.
I'm assuming the plans in the exchange are not limited to HMOs. No, there'll be a HMO and PPO type. Yeah, what the Exchange Board did, this is a summary of, if you actually go to their website, you can see the more detailed version. This is a little bit summarized. There's a more detailed version. They have a standard set of co-payments, which is typically what HMOs use, and then they have another version that has standard co-insurance rates, and that's typically what PPOs use. So both are, this is sort of a blend of that.
We have time, I think, for one or two more questions.
I understand the essential health benefits are a minimum set of benefits, but is it possible, if not probable, that plans would offer more in the exchange? Are they even allowed to?
If they do, the federal subsidy can't be used. I'm trying to remember the exact language. If plans are offering more than the essential benefits, they have to be paid for, I believe, by the state. I'm not entirely sure. I'm trying to remember exactly what the requirement is. But the point is that it's, well, outside, if you offer it outside, then the question is it still a bronze plan? Or is it a bronze plan plus? If it's a bronze plan and you offer more benefits and have to charge the same premium, well, I think you can do that, but then it's going to be a different version of that bronze plan. Yeah, it's going to be a different version. there is a strong disincentive. I'm sorry that I'm not remembering exactly what the law says. There is a strong disincentive to do it in terms of who has to pay for it. Yeah.
We have a final question back here.
Yeah, can you talk about how Covered California intends to mitigate the problem of adverse selection? The plans have to take all people with pre-existing conditions, but that doesn't mean they can't sort of subtly discourage them from enrolling by limiting their networks of specialists or putting a dialysis center in a part of town that's hard to get to, or offering health club memberships to attract healthier people. So what strategies have the architects put in place to mitigate this problem?
Okay,
or this
so I think of a plan tried to do that the Covered California has the authority to deem them not a qualified health plan, because there are other explicit provisions in the law, not in the regulations interpreting the law, but actually in the law, about providing adequate networks of providers, et cetera, et cetera. So it would be within the authority of Covered California to say that plan, we've reviewed the plan, and even though it meets these requirements, it doesn't meet the sort of minimal requirements in terms of the provider network, and therefore we're not going to allow the plan to be offered on the exchange.
Well, I want to thank Dr. Kominiski for coming.
Thank you very much.
Thank you all for coming.